The topic is endodontic-periodontic interrelationship or endodontic-periodontic lesions. So endodontic, it means where it is related to pulp, and periodontic is related to periodontium, that is the supporting structures of the teeth. Now how these two structures, they are interrelated and how they form a lesion. So this was first described by Simring and Goldberg in 1969. So the term pulpodontic and periodontic syndrome is a group of disease. So in this, now you will see there is also the involvement of pulp, and hence it was known as pulpodontic rather than endodontic before, and it is a periodontic syndrome, and it was first described by Bender and Schelzer in 1972. Now what is the definition of this interrelationship? So the pulp precedes the periodontal changes. Now what does this mean? So now the pulpal progression is basically very fast when you're comparing it with the periodontal changes. That means the periodontitis, so the progression of periodontitis is very slow. Because of that, it states that pulpal necrosis, it is always seen before the periodontal changes. So a periapical lesion which is originating in the pulpal inflammation and the necrosis, it may drain to the oral cavity through the periodontal ligament at the adjacent alveolar bone. So this is nothing but the both of these structures, they are involved, and because of this there is, for example, now a periapical lesion which is present. So this periapical lesion, it originates because of this caries. So because of this caries, there is a formation of a periapical lesion, and this, it may drain into the oral cavity through the periodontal ligament and the adjacent alveolar bone. So now how are they communicated, or what are the path of communication between the pulpal and the periodontal structure? So basically there are three pathways how they are communicated. So it can be the developmental origin, or it can be a pathological origin, or a iatrogenic origin. So developmental origin is because the structures of the teeth. So there are some structures because of which there is like communication between the pulp and the periodontal structures. So it can be apical foramen. So apical foramen, it is present at the apex. So because of this, now this apical foramen, so if there is inflammation which is present, so this inflammation, it goes through this pulp, and then it goes through this apical foramen to the periodontal structures. So apical foramen, next can be the developmental grooves, then there can be some accessory canals and the lateral canals. Now over here, for example, if there are some accessory canals which are present, so like this, there are some accessory canals. So through this accessory canals, the infection, it goes to the periodontal structures. Now the next is the enamel projection and the pearls at the cervical portion, and the next can be PDL and the alveolar bone. So these are the communication ways of the developmental origin. Now the pathological origin, it can be tooth fracture. Now for example, if your tooth, it is fractured, so there is pulpal involvement, and this can also lead to the involvement of the periodontal structure. So if there is a tooth fracture, or if there is idiopathic root resorption, or if there is loss of cementum due to the external irritants, and if there are any perforations which are present, so this becomes a pathological origin. And the iatrogenic can be root fractures due to endodontic procedures. So iatrogenic is because of the dentist itself. So if you are doing any endodontic procedures and at that time you like encounter root fractures, so this can lead to the communication between the pulp and the periodontal structures. Then if there is accidental lateral perforation, so this is like the endodontic failure where you perforate laterally. So this is the next like reason for the communication of the pulp and the periodontal structure. Then the next can be the exposure of the dentinal tubules following the root planing. So when you are doing the root planing, so if there is exposure of the dentinal tubule, so this can lead to the communication between the pulp and the periodontal structures. Now what is the Ethiopathogenesis? So basically your endo-PERIO lesion, they have three main etiology. So first is the anatomic consideration, then next can be contributing factors and the etiological factor. So anatomical considerations are because of the structure of the tooth itself. So it can be dentinal tubules, apical foramen, and the lateral and the accessory canal. So these is like the etiology of the endo-PERIO lesion for the anatomic consideration. The next is the contributing factor. So it can be if there is like poor endodontic treatment, so if there are any endodontic failures, so because of that also the etiology, so this becomes your etiology of the endo-PERIO lesion. Then if there is poor restoration, so that is nothing but again failure of the treatment. Then trauma, resorption, perforation, and developmental malformation. So trauma, it can be fracture of the crown, or there can be vertical root fracture. So this is nothing but trauma. So these all are the contributing factor which leads to the endo-PERIO lesion. The next are the etiological factors. So etiological factors can be live pathogen and non-living etiological agent. So live pathogen can be bacteria, fungi and viruses. So there are various bacteria which are present. So this Endo-PERIO lesion, it is caused due to various types of bacteria that can be Vonellina, then Peptostreptococcus, Spirochaetes. The next bacteria, it can be Fusobacterium nucleatum, then there is gingivalis and Treponema denticola. So these all are the names of the bacteria which are like the etiological factor for this Endo-PERIO lesion. Then there can be fungi and viruses, and non-living etiological factors can be foreign body and cholesterol. So this is nothing but the etiopathogenesis of the Endo-PERIO lesion. Now the next main part is the difference between the Endolegin and the Periolegian. So it is like commonly asked SAQ, like the differences between the endodontic lesions and the periodontal lesions. So first is the etiology. Now in endodontic, it is because of the necrosis of the pulp, and over here there is inflammation or infection of the periodontium. So because of this infection and inflammation, there is periodontal lesion, and in this there is necrosis of the pulp. The pain in this, now in endodontic, the pain, it is acute, excruciating and spontaneous in nature, whereas in periodontal it is dull and chronic, and because of that the patient, they usually do not come if they have periodontitis because they won't feel that pain. So in this periodontal lesions, the pain is dull. Then the swelling you will see is diffuse. Now if because of some caries, so if the caries, it has lead towards the periapical lesion. So if it has formed periapical abscess, so that means the swelling, it is diffuse, whereas in periodontal it is localized. The next is the percussion. So in endodontic, you will see when you're percussing the tooth, so when you're hitting, so you will see the tenderness on percussion, it will be positive when the patient will have any endodontic lesion, and when you're percussing in the vertical direction, so you're percussing like this onto the tooth occlusally. Then in periodontal, so the percussion, it is usually mild because the pain is very dull in the cases of periodontal. Then it is lateral in direction when you are percussing laterally and not vertically. So the next is probing. So in this, you'll see the probing depth of sulcus, it is less than 3 mm. Now it is endodontic lesion. So because of that, the gingiva, so the epithelium attachment, it is normal. So you'll see when you are probing it, so the sulcus depth, it is less than 3. The next is the sinus tracing. So a GP point, it leads to the apex of the involved tooth. So through the sinus tract opening, what you do is you like insert a GP point, and when you are seeing it, so it will lead to the apex of the involved teeth in the endodontic lesion, whereas in this, the gutta percha point, it will lead to the sulcus of the involved teeth. So this is nothing but the sinus tracing. Whereas now the next is the mobility. So now it is an endodontic lesion, so the supporting structures, they are intact and they are strong. So in this, it is rare, and if it is present, then it is localized. Whereas in periodontal lesion, now the supporting structures, they are only hampered in this periodontal lesion. So because of that, it is generalized and it is more common. Now the junctional epithelium, it is normal, and over here you will see the epithelium, it is migrated apically. In gingiva, again over here it is normal, and over here you will see there is gingival inflammation and there can be recession which is present. So the therapy for the endodontic is your root canal treatment, whereas over here it is a periodontal therapy. So periodontal, it can be scaling and root planing, then various surgeries which are there. Now the next important part is the classification of this Endo-PERIO lesion. So there are basically 3 classifications which were given by different people. So first is the Simon's classification. This is like the most important classification that you should know. So it is like classified into 6 groups. So first is primary endodontic. So that means it is only primarily an endodontic lesion. The next is primary endodontic with secondary periodontal involvement. So now over here, the main lesion was the endodontic lesion, and because of that, the endodontic inflammation, it has like been carried on the periodontal structures, and because of that, there is secondary periodontal involvement. Then the third is primary periodontal. So over here, it is only periodontal lesion and there is no involvement of endodontic. The D1, it is primary periodontal. So over here, the periodontal lesion, it was the main reason, and this lesion, it has lead to the involvement of the endodontics. So it is primary periodontal with secondary endodontic involvement. The next is the true combined lesion. Now in this, both are present. And the last one is concomitant. So now what all this are, like I'm going to explain them in depth. The next classification which is asked is the oliet and Pollocks classification. So they classified depending on the treatment protocol. So it is classified into 3 groups. So first is the lesion that require the endodontic procedures only. Next is that require only the periodontal treatment procedures, and the third one is the lesion which require both endodontic and periodontic treatments. So for example, in this, now the lesions which require endodontic can be if the pulp it is necrose. So any tooth with necrotic pulp and periradicular pathosis. So that is when you require only the endodontic procedures. The next can be if there is a periapical abscess which is present. So the next lesion that require only the endodontic treatment can be the root fractures, but they are horizontal or longitudinal root fractures. Then it can be like root perforations. Then it can be teeth with incomplete apical root development and inflamed or necrotic pulp with or without periradicular pathosis. Then reimplants, then transplant, then the teeth which require hemisection or the intentional endodontic therapy for the prosthodontic consideration. So this all it comes into the lesion which require only the endodontic. Now the lesion which require only the periodontic can be when there is occlusal trauma, then it can be when there is gingival inflammation, then it can be if there is pocket formation. And the last is the lesions that require both. So it can be any lesion in this group or in this group which leads to irreversible reaction in the attachment apparatus or in the pulp tissue. So this is like when you require the treatment for both. And the last classification it was given by Weine. So he classified it into 4 classes. So first class is when the tooth in which the symptoms clinically and radiographically they show that it can be a periodontal disease, but in fact it is a pulpal inflammation and or necrosis. So that means it is a class 1 where clinically and radiographically you will see that it can be like a periodontal disease, but in fact it is a pulpal disease. Class 2 is when the tooth that has both pulpal or periapical disease and periodontal disease concomitantly. So both the disease they are present concomitantly in the class 2. Then class 3 is when the tooth they has no pulpal problem, but they require the endodontic therapy plus root amputation to gain the periodontal healing. So in this, now class 3 is when you have only periodontal problem, but the periodontal problem is severe. So because of that, you also have to go for the endodontic treatment for the periodontal healing. Then class 4 is when the tooth that clinically and radiographically it stimulates that it can be a pulpal lesion, but whereas in fact it is a periodontal lesion. So it is like completely opposite of the class 1. So this is the classification which was given by Weine. So now starting with the individual lesion. So first is a primary endodontic lesion. So the etiology it can be dental caries. Now as it is a primary endodontic, so it can be the etiology is dental caries or restorative procedures and the traumatic injuries. Now in radiograph you will see there is a periapical radiolucency if there is a periapical abscess which is present and there is no loss of alveolar bone. So clinically you will see pain and tenderness to palpation and percussion, and if there is a sinus tract, if it is present, then it is traced to the apex of the involved tooth and there is abnormal response to the vitality testing. That means if, now for example, so it can be the endodontic lesion, so it can be vital tooth or non-vital tooth. So if there is necrosis of the pulp, so it will show some abnormal response to the vitality test. So that means that your tooth it is non-vital, and so the clinical feature for a non-vital tooth it will be asymptomatic. And as it is a primary endodontic, so the treatment is the endodontic therapy, that is your root canal treatment. So the next lesion is a primary endodontic with the secondary periodontal involvement. Now this is a endodontic lesion. First it was a endodontic lesion, and because of that endodontic lesion there is the formation, that is secondarily a periodontal involvement is caused. So in this there is progression of the untreated or the chronic primary endodontic lesion. So if your endodontic lesion it is not treated and if it is left for a very long time, so that means it is progressed. So that inflammation or infection it is getting progressed to the periodontium, and because of that the periodontal ligament or the periodontal structures they are also secondarily involved. Then the radiographic features is, now you will see there is periapical radiolucency and there will be some resorption in the alveolar bone. So over here now you can see if it is only endodontic, so there was only a radiolucency periapically, but over here now there is involvement of the periodontal lesion also. So that means you will see resorption of the alveolar bone also. Now the clinical feature is you will see there can be gingival inflammation, then there is lowering of the epithelial attachment as the periodontium is also getting involved. Then you will see there is plaque and calculus accumulation because now there is involvement of the periodontal structure, so it can also lead to the pocket formation. Now this is a chronic or untreated, so that means it is asymptomatic. So it would be necrosis. So that means it is like it will not show clinically any pain. So it will show all these gingival findings only. Now the treatment is, now as it is a primary endodontic, so first you are doing the endodontic treatment, and then after this you are going with the periodontal therapy, and it is like a root planing. So primarily first you start with the endodontic treatment, and after that you go with the periodontic treatment. So over here, now this is the diagram. Now for this, now this is commonly asked, so you should know the directions of it, because now these are like the arrows of it, so how it is like communicated, so you cannot draw it vice versa, it will be completely wrong. So now this is a endodontic, primary endodontic and secondary. So because of this caries, so this caries, it has involved in the pulp, and this involvement, so this inflammation which is involved in the pulp, it is going to the periodontium. So you have to make this arrows well. So it can be the involvement of the periodontal structures through the percussion canal. So over here, this is your percussion. So there are canals which are present at the percussion area. So this is like the one way through which the Endolegin, it is communicated and it is led to this Periolegian. The next can be your lateral canals. The next is the apical foramen. So now you can see this lesion. So this caries, it was causing the inflammation. So the inflammation is present in the pulp. So this, it can lead from this percussion canal, it is going to the periodontium like this. Now you can see over here through the lateral canal, it is going to the supporting structures. Then from the apical foramen, now you can see the arrows, it is going to the supporting of the periodontal structures. So this is the primary endo and secondary perio. So over here, now this is a primary perio and secondary endo. So now you can see the arrow, so it is completely opposite. So over here, the etiological factors for this is, the main etiological factor for perio is plaque and calculus. So now because of this, now you can see over here, so this arrows, so because of this, now like this, it goes into the from this apical foramen, it is going in the pulp. The next is the primary periodontal lesion. So the etiological factor is plaque and calculus. Then the radiographic feature, you will see there is, so there is bone resorption, which can be horizontal or angular, and there can be involvement of the furcation. Now it is only a periodontal lesion, so radiographically you will see this changes. Then there is tooth mobility, and there is normal response to the pulp vitality test. Now it is only primary perio, so the pulp, it is vital and it is showing normal response to it, and you will see only the clinical features which are related only to the periodontal lesions. Then the treatment is the periodontal therapy without any need for the endodontic intervention. So there are periodontal therapy, it can be GTR or root amputation or any other. The next is the primary perio with secondary endodontic involvement. So the etiological factor is when the periodontal disease, it progresses apically. The radiographic feature is, it may be identified to the teeth with periodontal involvement, although the bone loss, it is extensive. Now as the periodontal lesion, it is leading to the endodontic, so that means your periodontal lesion, it would be some severe type of periodontal lesion. So in this, the bone loss, it is extensive, and then it is like, you will see there is involvement of the endodontic lesion. The lesion, it exhibits the sign of the periodontal disease, such as there will be pockets, etc., and there can be the signs of the pulpal involvement, which includes the acute pain. Now over here, the treatment is primary endo followed by secondary perio. Now you would be thinking it is a primary perio, but the treatment we are saying is a primary endo. Why so? Now I'm going to give all the valid reasons why you should go for primary endo. So let any the region be rather than the primary periodontal lesion. So the treatment modality, it will always be, first you have to go with the endodontic treatment. You have to keep this in mind that whatever the lesion is, treatment modality is, first you are doing the endodontic treatment and then you are doing the periodontal treatment. Then what are the true combined lesions? So this, they are clinically not possible to differentiate. So which means that you do not know or you cannot differentiate which started first. So it was whether endo lesion, it causes the periodontal lesion, or whether it was the periodontal lesion, it caused the endodontic lesion. So you cannot differentiate. So that means it is a true lesion. The next over here, the radiographic feature is, it may show bone loss from the crestal bone which is extending down the lateral surface. Then the clinical feature is chronic lesion with gross pulpal and the periodontal destruction, you will see, as it is a true combined. So both the things are present. Over here again, endodontic treatment, which is followed by the periodontic treatment after a month. So if you will see, the endodontic treatment is successful. So after a month, you will start with the periodontal therapy. So that can be redisection or hemisection. So hemisection is when you are cutting the tooth into two, or redisection is when you're cutting one of the roots. So this is the treatment modality for a true combined lesion. And the last are the concomitant lesion. Concomitant is like they have distinct etiological factors. So both they have their own factors, and because of that, it has led to this concomitant lesions. So now both the disease, they are evident independent of each other. So both are present, they are independent of each other. So it's not like this lesion, it has caused to this lesion. So they are present independently. They both have their own factors. So that means there would be caries also, and there would be plaque and calculus also. So this is a concomitant lesion. Now again, both disease, they are treated independently, but first treatment modality is always the endodontic treatment. You have to remember this. So this is the diagram for the true lesion. Now you can see it is a two-way relation. So the inflammation or the infection, it is coming through this lateral canal and also going from this lateral canal. Whereas again from the Percussion canals, so again the inflammation, it is going and even it is coming, and from here also through this apical foramen. So this is like a two-way relation in the true lesions. So now, as I said, like why we are doing first the endodontic irrespective of what the lesion is. Just in the primary periodontal lesion, you're just going for the periodontal therapy, whereas in other 5 you're going for the endodontic treatment first. So it is like, it is recommended that the endodontic treatment, it should precede the periodontal therapy regardless of what the cause of the disease is. So for accurate diagnosis and the treatment planning, the clinician, they should be able to differentiate between the endodontic and periodontal lesion. So we have seen the differences between that endodontic and periodontal lesion. So now why the endodontic lesions, they are treated first. So first is the endodontic treatment, it is highly predictable. So it is like now in periodontal problem, so you will see that the lesion, there are many, and the procedures, there are also many. But in endodontics, you know, the treatment modality is only the root canal. Like the main treatment modality is root canal. So it is like highly predictable. So this is one of the reason why you have to go with the endodontic treatment first. Then the next is the periodontal component, it cannot resolve till the endodontic lesion is present. So if the endodontic lesion is present, so until and unless it is not resolved properly, so there would be like, there is continuous bacteria which is present. So unless you are treating the pulpal problems, your periodontal problem, it won't resolve. Then the next is the progress of the periodontitis is very slow with the exception of some acute diseases. So therefore, the prompt management of the pulpal lesion, it is a primary concern. So that means when there is a pulpal involvement, so the pulpal, like if there is caries, so the caries progression is very fast, and the patient, like we have seen, there is like acute pain. So because of that, you always have to go with the endodontic treatment first, and then you're going with the periodontal therapy, irrespective of what the cause is. So this was all about the endo-perio lesion. I hope you found this video helpful, and if you did, then please like, comment, share and subscribe to my channel. Thank you so much.